Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
Hey everybody, welcome to the Wild Health Podcast. Mike Mallon here. I have with me Dr. Mike Stone. Hey Mike, how you doing?
I'm awesome, Mike. How are you?
Doing pretty well. Mike and I, other than just recording the podcast all the time, also are sort of in charge of research here at Wild Health. And we got some pretty good news. We just published a study in Frontiers of Medicine back in October 23rd, 2023, called a pilot retrospective study of physician-directed and genomics-based model for precision lifestyle medicine. We're pretty excited about this, and I wanted to have Mike here on the podcast because he obviously played a big role in the research project itself, and because he's just so good at explaining things, to come on the podcast and help us with kind of going over the outcomes of the study and a little bit about why it's so important, I think. So, Mike, do you want to start maybe by just kind of telling us a little bit about the background of the study and start there?
Yeah, for sure. I think excited doesn't even really begin to touch it for anybody who's done clinical research of any kind. And for those who haven't, just for context, it's a slog, right? Everything from study genesis, the idea generation, to coming up with how you're going to structure the study, to the data collection, to the data analysis, and then to the manuscript writing and the manuscript editing and the back and forth with peer review. So the peer review process is rigorous, right? It's so that when you read something in the peer-reviewed medical literature, you know that people who have nothing to do with the study and no bias and no reason to say that the results are good and valid have looked at it and said, yeah, this is worth publishing. So we worked hard. This was not just on a whim to go ahead and write some results up.
Actually this started 5 years ago, I guess, in terms of like data collection. But even just in terms of like, hey, we're going to write a paper, started over 2 years ago because we got IRB approval over 2 years ago. And then it took well over a year to actually get to publication. So yeah, this was not we just like were bored on a weekend and decided we wanted to write a paper. Not exactly how it went.
Yeah. Yeah, just a little peek behind the curtain. It's and for folks who are involved in clinical research, no surprise there. I mean, it's pretty typical to be rejected from a number of papers during the process. It's typical for it to take 6 to 12 months on the low end from designing a study to getting it even submitted. So my arm's sore from patting ourselves on the back about getting this over the finish line. But where did this come from? You already alluded to it. We started seeing patients 5 years ago, and we started having, what I would consider experiential, anecdotal evidence of improvements in health outcomes in the folks that we were treating. And it's part of why we've been so passionate at Wild Health, is we really believe that our approach of genomics-based lifestyle and medical interventions, managing chronic disease and improving overall health really works. So what we did was, as a pilot observational cohort study, involved just under 900 patients, so 871 patients. And we really looked at the effects of the Wild Health program overall. So somebody comes and enrolls with us, we get baseline laboratory markers on that patient, along with genomics and interviews and surveys and health coaching and physician visits. And then we looked at what happened to their biomarkers, key biomarkers of chronic disease, over the time that they worked with us, and it was over a 12-month period. So that's sort of the basics of the study. Mike, maybe you can elaborate a little bit about what the lab testing and the genomic testing really looked like for these folks.
Yeah, so we wanted to do a study on, the standard wild health experience. So this wasn't, a really this wasn't designed outside of real world analysis, right? So we took, real world patients who were getting the real world wild health experience, which includes, DNA testing, right? So you spit in a tube and send it off to a lab. We use LabCorp for our DNA testing, as well as, sort of expansive biomarker, blood marker analysis, right? So, these are all the labs that you guys have heard us talk about on the podcast before, things like your lipids, your advanced lipids, your hormones, your micronutrients, some of your vitamins and minerals, markers of chronic disease, the things that Mike mentioned, and I'll go over some of those as we're looking at the results. But, basically what we did was first get the genetics, get the labs, put those into the Wild Health algorithm, which we use on all of our patients. It spits out a health report. That health report tries to assimilate all of that data along with questionnaire data to make recommendations about, the type of diet you should be eating, the exercise that you should be doing, the sleep that you should be getting, and any risk factors for chronic disease, cancer, cardiovascular disease, dementia, inflammation, insulin resistance, all of those things, with spitting out recommendations for how to improve or prevent those disease processes. And we use polygenic risk scores for that. We use a combination of labs and singular SNPs, all sorts of things to help us deliver those specific recommendations. But all of these patients, the 871 patients, they all got, basically the same care, different providers, but all wild health care, right? And then what we did was we looked at their biomarkers when they first signed up with Wild Health, obviously ran their report, delivered them health care over the course of the year. And then we looked at how their biomarkers changed over that course of the year to see what sort of intervention Wild Health had on these patients. So there's not really a control here because we're just doing an observational study. A control is where you deliver standard care, but the patients are sort of their own control, right? They came to us getting standard care somewhere else in the health ecosystem. And then we intervened, and then we looked at the effect that intervention had then on their health outcomes and their biomarkers. So when we did that, we found that we had a pretty remarkable improvement in a lot of biomarkers. So if you look at all of the biomarkers, and there's about 40 that we tested on these patients, there was a resolution of out of range biomarkers 30% of the time. So that means that people who came to us with an abnormal biomarker, 30% of them had complete resolution of that biomarker. So we looked at specific ones as well, like for example, hemoglobin A1C, low density lipoprotein particle number, and C-reactive protein. And those were the most remarkable, and those are the ones that we mentioned in the abstract of the study. But let's talk about those real quick. So for hemoglobin A1C, 47.5% of the patients who had a hemoglobin A1C that was out of range had resolution of their hemoglobin A1C. Mike, do you want to just comment on what that actually means?
Yeah, 100%. So hemoglobin A1C it's not a perfect test, but it's a pretty standard test to give you a sense of what your average blood glucose looks like over the 3 months prior to the test. So you can imagine, if you go in and you get a blood glucose done at the lab, depending on what time of the day you're getting it done, what you had to eat, whether you fasted, you didn't fast, whether you exercised before, there's a lot of variability in what that glucose, that spot random glucose will look like. But a hemoglobin A1C is a great test because it gives you a sense of, hey, what have my glucose numbers been doing over the last 90 days? 5.7 to 6.4 is an indication of prediabetes. 6.5 and above meets criteria for diabetes. And, under 5.7 is normal, whereas really kind of under 5.2, 5.3 is optimal. So we looked at folks who had hemoglobin A1Cs over 5.7 or above, so pre-diabetic or diabetic. And 47.5% of those patients, so that's pretty darn close to half of those patients, normalize their hemoglobin A1C. So that's a biomarker indication of reversing diabetes or prediabetes in half of the patients who worked with us over just the course of a year or less. And what's really remarkable there is in this study cohort, I don't think we had you can correct me if I'm wrong, we might have had one. I don't think more than a one or two patients tops was actually prescribed a medication to lower their hemoglobin A1C. So it's not like people signed up with Wild Health. We put everybody on, semaglutide, or we put everybody on metformin or insulin, and then we said, hey, look, we got 50% of them into the normal range. This is with polygenic risk scoring, physician oversight, health coaching, and lifestyle intervention. That is, kind of incredible, because you look at, it's unparalleled. And what's amazing is even within that, like when you're looking at observational data or any kind of epidemiologic study, one of the things you can use to determine, like, hey, is this real? Like, does this make sense? Can I believe this? Because it's not a random, and we're going to talk about limitations. It's not a randomized control trial where you put half the people into our program and half the people went and saw their primary care docs, and everything else was matched in terms of age and gender and comorbidity. This is a pilot study. That's why it's in the title. A couple of the things you can look at, though, to say, hey, does this make sense? Is this likely true? Is there a causal relationship here? One is, does it make physiologic sense? And the answer is yes. The lifestyle interventions that we typically coach folks on around improving their insulin sensitivity and decreasing their odds of having prediabetes or diabetes, those are all proven techniques, and that makes sense. And then two, is there these aren't the only two criteria, but they're the only two I'm going to bore you with right now. Two is, is there a dose-dependent response? So you think about, looking at smoking, right? Like, it's not like the original studies looking at lung cancer in smokers had people randomized to smokers and non-smokers in a prospective way. You looked at a population of smokers, you looked at a population of non-smokers, you saw that lung cancer was more common in the smokers, and you saw that there was a dose-dependent response. If you smoked 3 packs of cigarettes a day versus 1 cigarette a day, your odds of developing lung cancer were much higher with a higher dose. And what's really remarkable here is, in the patients, the highest quartile, so the highest 25% of A1C levels, those patients had an average 1.9% improvement in their hemoglobin A1C. So just for context, if my hemoglobin A1C were 7.9, that's like really poorly controlled diabetes.
Mm-hmm. Full on diabetes. Yep.
Afterwards, it would be 6.0, and I would actually be much closer to normal than I am to even diabetes. I'd still have prediabetes at 6.0, but a 1.9% improvement is something you don't see anywhere in the medical literature. I mean, health coaching programs, medication interventions, if you're really knocking it out of the park, you're probably at like a 0.7, 0.8 reduction in terms of hemoglobin A1C. A 1.9% improvement's really unheard of. I thought that of all the results, and there are other ones we'll dive into, the impact on insulin sensitivity and metabolic health was, really exceeded what even I thought we were going to see, having worked with many of these patients and seen improvements. I didn't think it was going to be this significant of a reduction in hemoglobin A1C. So I don't know if you have anything else to add on A1C, but that one, that really surprised me.
Just if you look at the metformin data, you're talking about a 1.9% reduction from baseline. If you look at the metformin data, the best you're seeing there in the best studies is 1.1%. So nearly 2x effect of the Wild Health intervention as compared to metformin. Obviously, we didn't directly compare these, but looking at the research, that's what you're seeing. And then for metformin, we expect a remission rate of diabetes of around 3%. Which is quite different than the 50% that we saw in our pre-diabetics and diabetic population. So, I think if nothing else, this is just a reminder for me that how powerful lifestyle intervention can be if delivered in the right manner. The studies on lifestyle intervention that we do have, that we usually compare medications to, are not done with a modality like Wild Health. They're done in a very traditional healthcare system where you see your provider once a year, maybe for 15 minutes. You don't have a health coach. You're not getting significant recommendations or lifestyle interventions. It's just like, hey, eat better and exercise. Like, that's literally the conversation that a lot of patients have with their physician.
Eat less, move more.
Yeah, it's no wonder that people don't have this kind of improvement that we're seeing with Wild Health in the traditional healthcare system. So, I thought that was really remarkable. I love the fact that we were able to actually sort of indirectly compare our outcomes with diabetes as to metformin. I thought that was really cool. So other areas that I think are worth talking about.
Oh yeah, sorry. I think we got a tiny delay here. I was going to say it wasn't just hemoglobin A1C though. So yeah, tell us about what about LP little a, or sorry, not LP little a, LDLP was the large cholesterol marker we looked at.
Yeah, so we also looked at two other markers, low-density lipoprotein particle number, which, let me just describe what that is for people real quick in case they haven't heard on other podcasts. We've definitely talked about this before. You can search back in other cardiovascular disease podcasts that I've done with Mike or even further back in our repertoire. But the LDL particle number is similar to LDL concentration. So when you go to your regular doctor and you get an LDL concentration or a cholesterol test, they're looking at the concentration of cholesterol in your blood, right? And that's okay as a starting point for evaluating cardiovascular disease risk. But a better marker for that is something called LDL particle number. And that's similar to ApoB, if you're familiar with what ApoB is, but it's looking at the actual particles of LDL in your blood. And the reason that's important is because the particles themselves are what lead to the plaque development and the risk of cardiovascular disease rather than the concentration of LDL cholesterol. And you can think about it like this. Cholesterol particles are different sizes. They're not one size fits all, right? You got big fluffy particles and you got small hard particles. The big fluffy particles are going to give you a lot of concentration for a single particle, right? Because there's a lot of LDL in that particle. Whereas the small hard ones are going to give you a low concentration for the same number of particles, right? So you can get an LDL concentration number that looks normal, but have lots of particles because they're all small and hard. And if you have lots of particles, you've got a higher cardiovascular disease risk. And what we know is that people with more small hard particles have a higher risk than people with big fluffy particles. So for that reason, we choose to look more primarily at LDL particle number rather than concentration as a measure for cardiovascular disease risk. And just like we did with hemoglobin A1C, we looked at this cohort of patients in these 871 people. And for those people who came to us with an elevated LDL particle number, we saw a 33% reduction or resolution in elevated LDLP over that time frame. Again, predominantly with lifestyle interventions rather than statins or other medications. So this is on par with, actually better than typically what you see with a statin. So most people expect around a 25% resolution of an elevated cholesterol level associated with statin use. We got 33% with lifestyle. So pretty happy about that improvement as well. And then CRP. Another really important area when it comes to chronic disease prevention, overall health. That's why, we tried to focus on insulin resistance, cardiovascular disease, and CRP, which are, I think probably the three biggest biomarkers when it comes to longevity and overall health. Because CRP, just like hemoglobin A1C is associated with insulin resistance and LDL is associated with cardiovascular resistance, CRP is really associated with everything. like literally almost every disease process is worsened by inflammation. And that's what CRP is measuring, is a general marker of low-grade inflammation in the body. So looking at CRP, we found a number of our patients came into the cohort with elevated CRP. And when we looked at those who had complete resolution, again, about 33% of our patients had complete resolution. So I think what we're seeing here is a really strong improvement in these biomarkers in general, and then a large number of patients who are not just improving, but actually having resolution of their disease process, no longer have inflammation, no longer have elevated cholesterol, no longer have hemoglobin A1C elevations or diabetes, which is really pretty remarkable.
Yeah, I think that's worth an exclamation point and just emphasizing is when we say 33% for LDLP, that doesn't mean that if I had a LDLP that was 1,000, that it came down by 33%. It means that 33% of the patients who had LDLP above normal resolved into the normal range. So that's a really important point to clarify. And then you might be wondering why we didn't look at ApoB, and I think it's just worth explaining that, although I don't think we actually talk about this in the paper. But 5 years ago, people weren't really routinely checking for ApoB. So while we certainly could run this today prospectively with our current patient population, where we are routinely checking ApoB and have been for over a year, 5 years ago with this prospective data, LDLP was the really best marker for the types of LDL particles that are associated with invasion into the endothelial wall and into the vascular wall and the risk of atherosclerotic cardiovascular disease. So I would wonder that if I was reading this paper, hey, why'd they look at LDLP instead of ApoB? And I think LDLP is, as you mentioned, Mike, like a great proxy and substitute when you have that in the data, as opposed to looking at just LDL concentration. You had a much more elegant way of putting it. I just think of LDL-C and, you either have these big fluffy particles that kind of like bounce off the walls of the blood vessel while they're floating around like sponges and they're all happy and soft, or you've got these little dagger-like tiny BB gun pellets that get into the wall. But I simple brains. This is how I manage getting through the day. All right. Limitations. Should we talk about some limitations of the study? I think, it's an observational study, and and we used retrospective data. So that's clearly the sort of holy grail of, and we've talked about this on the podcast, and anyone who's learned or heard of how to evaluate the medical literature knows some of this. So I'll be pretty brief with it. But the holy grail of prospective of clinical research is a randomized controlled trial, and then you could certainly make the case that a really well done systematic review or meta-analysis is also right up there. So randomized controlled trial is exactly what it sounds like. Ideally, you have a group of people you want to study something. You randomize people who are matched by all of their demographics, so gender and age and comorbidities and habits. And the patients don't know which arm they're in. They're blinded to it. You're doing an intervention of some kind, whether it's lifestyle or medication or supplements or whatever it is. And then you're following out and seeing if there's a difference between those two groups in terms of an outcome that you predetermined. A well-done meta-analysis or systematic review basically looks at a number of high-quality randomized controlled trials, and you're able to get a higher number of patients to look at because you're including all the numbers of the patients from all of the individual trials. This study is neither of those. This is an observational study where we looked at a group of patients who signed up with us, and we looked at the data retrospectively. There are potential biases as a result. So sufficient data bias. So for example, like if we didn't have enough data for a patient and they didn't have repeat labs, they might not have been included. Healthy user bias, right? If we had a bunch of really motivated biohacker patients who came in and wanted to just do everything they could to optimize their health, that doesn't impact the validity or the accuracy of the results, but it does have an impact for generalizability, right? If you have somebody who isn't going to change their nutritional strategy, isn't going to change their sleep or their training or their stress resiliency or any of the other things that we talk about at Wild Health, if you don't change your lifestyle medicine interventions probably aren't going to help you achieve the same outcomes. So that's certainly a limitation. That said, biases and limitations are there to help you create a foundation for future more rigorous studies. So this is, I think, well beyond hypothesis generating. I think this is really compelling data that this program works for patients who enroll. Now, in terms of how to make it the most generalizable, how to really nail down the effect size of the intervention, that's where we would need a prospective study and ideally a randomized controlled trial. Would love to hear if you think there are other big biases or limitations that I'm leaving out. And then would love also, Mike, just to hear sort of like what are the future implications for precision medicine that focuses on lifestyle, especially in the context of chronic disease management, that you think might be illuminated by this study?
I mean, I think you hit the major biases. The biggest one really being the healthy user bias, I think, is the biggest challenge that we have. Although, healthy user bias, really more of active user bias, I think, because if you look at our cohort, there's plenty of sick people in our cohort, right? Like we reversed a good bit of diabetes, we reversed a good bit of cardiovascular disease risk, but certainly people who are motivated, right? Because they're coming in, they're paying for a program. So from a real world perspective, I think for me, that's very helpful, right? Because, medicine happens in the real world. It doesn't happen in a lab. It doesn't happen in a controlled setting. So this tells me that, there's certainly a signal here, and the people who come with motivation are likely to improve, given the study. That may not be true if you took a cohort of patients who are not motivated, right? Those patients might need to be put on medications because they're motivated enough to take a pill, but not motivated enough to do the lifestyle intervention. As far as what this means for the future of precision medicine, this is, as far as I know, Mike, the first study that looks at precision medicine applied in a generalizable way to lifestyle intervention. There are certainly smaller studies, right? But they've been looking at, if people have this one SNP and you do this particular diet intervention, what is their outcome? This is a very general, broad application of a precision medicine program to a population of patients. And as far as I know, this is the first of this scale. So for me, this is really a landmark time for precision medicine, which has traditionally been focused on very stringent, narrow populations of patients, and typically in the cancer research world, looking at genomics and how those play a role in the delivery of care. And this, for me, hopefully is going to open up an area of research that looks at, how do we take this precise genetic and laboratory biomarker information and apply it to a larger population in a lifestyle format that can change the way that we intervene from a lifestyle perspective. So I hope this is the beginning of a new area of research that is looking at this area of precision medicine and primary care and an application of different modalities to change people's health. I think that I'd love to do a randomized controlled trial, but it'll be interesting to see if we can pull that off. For listeners that don't know, those are really expensive and very, very challenging to do. Typically done by academic institutions. We are, while Mike and I have both been at academic institutions and performed randomized controlled trials at academic institutions, doing so in a private company is a little bit different. So I don't know. I would definitely like to do a prospective study where we're prospectively collecting data. The challenge is then, are we going to do a control arm? And if we do a control arm, what do we control people to? And do I feel comfortable controlling people to traditional care? I don't know that I do, to be honest.
Yeah, I mean, I think this would have to take place in collaboration with the traditional Western healthcare system, where the control arm were matched patients who, first of all, you can't randomize people to lifestyle intervention. The amount of sham lifestyle intervention you'd have to create to have a control group. So in the study group, they're increasing their dietary fiber to 40 grams a day for an adult male, and in the sham group, they're reducing their fiber to 0. I mean, it's I don't know. It seems very unethical to be advising people on anti-lifestyle medicine techniques. You could, on the other hand, so it probably wouldn't be a blinded study, but you could certainly have matched controls who were in a traditional primary care or family medicine practice, and then matched study participants who were working in the Wild Health program. But I, for one, can guarantee that we will not have a control group at Wild Health where people sign up to really optimize their health and improve their longevity and health span, and then we randomize them to doing what they would normally do if they went and saw a traditional Western primary care practice. So that's not happening. I just wanted to add one other thought that came up for me while you were talking about active users and healthy users and this idea of motivation. And this is this is a nod and a shout out to our health coaches, because, what's really different about our program? Like, yes, you built an amazing AI system that does polygenic risk scoring and incorporates multiple patient-specific factors and gives recommendations that are really tailored to that person. There's no question that the algorithm and clarity have been super impactful on patients. But some of the folks in the strength and conditioning space have this model that I've heard tossed around. I did not create this, so I just want to say that, although I don't know who I heard it from initially. But it's this idea that there's maybe 5 or 6 strategies to really make something into to incorporate something into your life and to encourage adherence. And it's not really strategies as much as a progression. So you start with inspiration. Right, you see a Bruce Lee movie, and you're like, I'm gonna learn kung fu because that is awesome. And then you go to motivation, and maybe you like go online and try and find a place near you where you can learn martial arts. And that's where most people drop off, is at the motivation stage. So we have motivated patients who sign up. Something inspires them to do something about their health and to reconnect and to make this a priority. And then they're motivated enough to come to us and say, hey, help me. But then getting them through intention, discipline, habit, and ultimately to passion, where like they're working out, let's say as an example, they're doing resistance training 4 times a week. They're doing it because they love it. They're not doing it because it's a willpower issue or it's a grind or somebody told them to do it. They're doing it because they really want to, and they love how it makes them feel, and they believe in the value of it. And it's just something that they're going to do, like brushing their teeth. It's part of what they do. That transition from motivation to habit and through all those stages along the way, that's health coaching. And I think it's, it would, again, I wouldn't want to be part of a study where we had some of our patients assigned to health coaching and a control group that got the same recommendations, but without health coaching. But I would wager a guess that group would have significantly less impressive results. So
I'm confident of it, actually. So
Yeah.
to stop you real quick, Mike. So I do have some of that data. We've run this analysis on our current patient cohort, and without a doubt, our outcomes are improved on a biomarker level, and even a subjective level, the more visits that patients have with health coaches. So there's definitely a signal of, and this makes sense to some extent. Like, the more motivated you are, the more likely you are to have better outcomes. But it says, for me at least, that there is a direct relationship with the amount of visits you have with your health coach, the amount of interaction and messaging you have with your health coach, and your overall health outcomes. And that's probably, honestly, that's probably a study that we should also try to publish, because, I think while that's something you and I get because we see it every single day, right? Like, I'm not sure the healthcare community understands that. The value of health coaching is not something that I think is ubiquitously understood and appreciated in healthcare, and maybe something that should be, definitely something that should be.
Every time you come up with a new study, I get this really uneasy feeling in my stomach, and I just breathe through it, and it tends to go away. But I just start flashing forward to all of the work involved in actually doing that study. But I have seen our data around that, and just want to give a quick shout out to the docs too. We also see a similar signal with the amount of physician interaction that patients have. So I think some of it is just how engaged are you with your healthcare, and how active are you, and how top of mind is this. But if I had to guess at a head-to-head, I would bet that the impact on frequency of health coaching visits probably outweighs the impact of frequency of physician visits. I think that, at least speaking for myself, and I wish you were my doctor at Wild Health just so I could get a dig in on you here. You're not my doctor, but what's up, Carl? Speaking as a patient at Wild Health, my health outcomes have improved tremendously, and I credit 20 to 30% of that with my physician and everything that Wild Health does with precision medicine, and the remainder, the majority, to my coach. So shout out to Nate Barry, and big believer in health coaching. I think it would be worthwhile, as much as it hurts me, to figure out a way to actually quantify and study the impact that our health coaches have. Because I agree with you. I think it's not something that that's well understood or well recognized in the current medical climate.
All right. Well, I have a little bit of regret now that we even had this podcast, because now we just give ourselves more work. But I'm glad that we had the opportunity to pat ourselves on the back and share this paper with everybody else out there. If you're interested, the paper's open access. We paid extra for that, so you can go and download it. And you go to PubMed, or you can go to Frontiers in Medicine and check it out. There, we actually published all of the biomarkers, so you can look at every biomarker that had any effect whatsoever, or actually whether it had an effect or not. We published all the biomarkers in a very large table, so you can actually go in and look and see how everything changed, if you're interested. And yeah, thanks, Mike, for coming on and discussing this with me, and good to talk to you.
Yeah, man, really appreciate it. Last thing, for people who are like me, a little like impulsive and just want to go ahead and find the paper and don't want to look at the show notes and get links and that kind of stuff, if you just Google PubMed, PUBMED, it'll take you to the National Institute of Health peer-reviewed literature, and you can just type in 37942418. 37942418 in the search box. That's the PubMed ID. It'll take you directly to the paper. You can download the PDF and check it out. So thanks, Mike. Thanks for slogging through this 2-year process with me to make science better. And now we can get back to the drawing board and see how we want to torture ourselves next.
Thanks, Mike. Have a good one.
You too.
Hey everybody, a quick note about our precision medicine training program. It's been a really popular course. We're constantly hiring health coaches and physicians, but we're only hiring them as we grow if they're trained in precision medicine. You don't get that in medical school or other places. And so we've developed this training program, and we've completely revamped it recently. It's a lot more robust. So now there's still over 50 hours of live synchronous training. There's also all the asynchronous credit, over 50 hours of content. And as a physician, you get about 50 hours of AMA Category 1 CME credit, which is a nice benefit. For the health coaches going through the training program, it's now accredited by the National Board of Health and Wellness Coaching. So graduates are going to meet the requirement to sit for the board exam and become board certified health coaches. So there's a lot of benefits to that, not just the certification, but also when it comes to things like insurance reimbursement. So it's a really robust program. If you're a physician, a nurse practitioner, a PA, or someone that just wants to be a health coach, it's open to all of those categories. There's the 6-month program that's kind of the full program. And then we also have just a fundamentals of precision medicine course, which is completely on your own. It's online. It's all asynchronous. You still get the 50 hours of AMA Category 1, but it's self-paced, and you still have access to the online community, but not all the synchronous lectures as well. So if you're interested in checking that out, go to wildhealth.com/education, and we'd love to have you as part of our next class.